Chairperson. Thank you, Pradeep, for inviting me. This is slightly offbeat talk because it talks about the recent advances in acetabular imaging. Um, in accordance with the theme of the conference, it's about adapting and evolving with time. A lot has changed, but thankfully, some things have not. And we are all here. We know that the anatomy do not change. We know that the X-rays are still relevant. Judate view, inlet, outlet view, 6 golden lines that we are taught is always something that we all should know. We must know how to take obturator views, again standard things that we all must know. So I'm not going to deal about these things because these are standard, but the point I'm trying to make here is that some things have not changed and this will never change. We must know how to read good X-rays, how to look about CT scans, the concept of roof arc angle, that's something that we all must know. We all know this. What's new? This is one of our recent publications in this, in which we have changed how we look at roof arc angle, and someone who's interested can go through it. CT scans, again, I think we should look at the orientation of fracture line, look at the position or quadrant of the fracture, look at the level of fracture. So 3 things, anterior, posterior, we all know that here. Since all of you are attending here, I'm presuming that we've got basic knowledge of CT scans. So, but all of this is very important because you get to know. If you know this, then you can use the advanced technologies to kind of orient yourself better. Standard things, they're beautiful lectures. I think training and teaching has changed, and I think that's where we are. So we all know about this. 3D reconstructions, I think, again, I will not call it new, but something, I think this is the single most important innovation that has happened in last 3 decades about being able to reconstruct and understand the anatomy better. But if we are good, we need to become better. We are humans and we have always pushed boundaries, and that's where this entire talk is about. And I think one of the key things that has happened is segmentation by surgeons. I know it sounds too technical. There are 3 important softwares any pelvic acetabular surgeon should know about: HOROS, Osirix, and 3D Slicer. Fortunately, 2 of them are free, and anyone who is interested in training in pelvic acetabular surgery must know about segmentation technique. 8-minute talk is too short to speak about segmentation. Segmentation basically means it involves 2 processes. One, kind of identifying the region of interest, and second, setting up the thresholding pattern to know what structures are bone. There's a good tutorial on 3D slicers from a 3D printing workshop that we conducted at our hospital, and anyone who wants to read can do it step by step. But I think this is very important. Another change that has happened is that you are now get automatic segmenters, and there are also third-party agencies who do the segmentation for you, and I think this has made life much easier. The second thing which we've been hearing in this decade is about 3D graphy, and you'll see how acetabulum is being printed with using the 3D printers. So you'll see the top part is the ileum, the below is the support system. I call them jalebi makers, but automated jalebi makers. So whatever the CT scan you give to the computer, it stacks up layer by layer, and the nozzle that you are seeing there throws out a small plastic, which because of its heat sticks to each other. So just like the CT scan axial cuts, the layers are laid on the top of each other, recreating the acetabulum. So this gives you model, and these are the models that you can get of the fractures. But what is important, the different type of fracture pattern makes it easier for someone to recognize the fracture pattern, and most importantly, play with it. And this is how, so when I do acetabulum, I also get a 3D printed model of the opposite side. It helps contour the plate. So one, the injured side, you can know about the anatomy, you can see the fracture pattern which is torn, and the opposite side, you can contour the plate. And trust me, it saves at least 40% of your surgical time if you do it well. So that's how we've contoured the plate, and the implantation time sometimes can be reduced to as less as 20 minutes. Another thing that has happened, and especially if you are into the percutaneous realm, is the patient optimized surgical tools, and you can plan your trajectories on these softwares. So I'm using and choosing the screw length here. This is again a free software called as Blue Sky, which dental surgeons use, but we are using. So I'm planning my trajectory here, going from posterior to anterior, seeing where it is fitting in. And once I've done, I'm happy with the trajectory, I can print a reverse model to give me a percutaneous jig for fixation. It can be done anywhere in the body for high tibial osteotomies, for pelvic acetabular fracture, and it is pretty much easy. The whole point of this talk is to kind of just give you an insight on what you can do as technological persons also when you are operating, and being in that field helps you not only to understand better, but to execute better. Moving ahead, the imaging has moved to the era of getting 3D printed implants where you can actually print different size and you are not limited with certain plates or screws that you have. People have done a lot of innovations in getting newer plates in your system, but I think in a decade's time that will become obsolete because we have moved into the era of a patient-specific implants and you'll be able to kind of think and design the implant that you want. This is the intra-op cone beam CT, which I think again is one of the revolution. This is from my own hospital. I am not doing as much acetabulum now because I'm at such a tip apex of the South Mumbai that we rarely get pelvic acetabular traumas there. But this is a beautiful system. We have done a lot of elective surgeries, a lot of osteoid osteomas using these cone beam CTs that we have intraoperatively, and you'll see this table kind of moves in and out, and the CT machine moves in and out, and all of those things that you are seeing can be done by doing an intra-op CT scans. So this cone beam CT is very useful, and I think those centers which are doing dedicated pelvic acetabular work should consider either in this or investing in O-arms. Again, this is an O-arm which is kind of a CT scan, taking the images with the spin, and you get very similar images that I showed you in last thing. So you get these kind of images, you can see your accurate trajectory plan and intraoperatively change things that you wanted to do. So yeah, so that's about it. In an 8 minute, it was only a brief kind of snapshot of what is all available to the domain of pelvic acetabular surgeon. And I thank you for attention and welcome any questions that you may have.